Hi, everybody. A very, very good evening to each and every one of you out there. Of course, at the beginning, I want to thank the organizers for inviting me over here and making me a part of this lovely evening. And actually, a big thank you to all of you all sitting over there, because I know it's been a long day, and I really appreciate the fact that you're really hanging out there. You know, Ramadan is now 1.5 months down the line. It's Rajab has started according to the Islamic calendar. And I'm sure you are now, as a clinician, going to face a number of patients who are going to come to you and ask you, sir, ma'am, can we fast? The first question. The second question, is it okay? I mean, and if you answer in the affirmative, things are very easy. If you answer in the negative, and in spite of that, if the patient says, okay, no, but I still want to fast, that's where all the issues start for us practically. As clinicians, what we have increasingly seen as we go along the line, for us, two very, very important factors play a very, very important role when we are clinically managing our patients. One is, at this point of time, we do have an increasing amount of data which tells us that, yes, we can allow our patients to fast if they are in the low risk and the moderate risk category without a major problem. So when your patient first walks into that consulting of yours, the first issue that you have to tackle is that in which category, according to the IDF-DAR guidelines, does this patient fit as to whether it is okay for you to allow this patient to fast. Subsequent to that, you come to the next step where once you've decided that, okay, I'm going to allow my patient to fast, and you'll both mutually decide that it's okay if you fast, then the second step comes where you decide what kind of medication you can allow this patient to continue taking during that entire period of fasting. One very important point that I want to bring across over here is that we have to remember, when we are talking about fasting, we are also talking about feasting. Believe me, the period of Ramadan is not only fasting. There is a spiritual element to it, which is fasting, and there is a big social element to it, which is feasting. The one time of the year when my patients very categorically tell me, madam, I am not going to follow any kind of dietary restrictions. So your job and my job together becomes that how do we allow our patients to go through this entire period safely? How do we see to it that they do not land up with too much of glycemic variability? And how do we see to it that at the end of that 1 month of both fasting and feasting, your patient is still relatively fine as far as the patient's glycosylated hemoglobin goes and the other parameters go? To add to this entire situation, we in the Asian countries face another problem, that is a number of our patients. I'm sure you and I still use a lot of sulfonylureas. Almost, I would say 60% of our patients are still on sulfonylureas, or 70%. How many do we think? 60%, right? I think, or maybe 70% also. Because we still, I mean, in spite of everything that we are reading about, we still believe in the safe and smart use of sulfonylureas. So almost 60% of the patients who are coming to you for a consult regarding fasting during Ramadan are going to be on some kind of sulfonylurea. And the moment you say sulfonylurea, you have an inherent fear, oh, is my patient going to go into hypoglycemia? A very, very inherent fear that, yes, I do not want my patient on sulfonylurea to fast because this patient is going to go into hypoglycemia. So what do we do about a great chunk of 50% patients who want to fast and who are on sulfonylureas? And for example, I have not come to you now during Rajab, say 6 weeks before, but I have come to you just 4 to 5 days before Ramadan, and they're telling you, oh, sir, I want to fast during Ramadan, please help me out. With this kind of scenario in mind, this entire study was conceptualized. Why was this study basically conceptualized? Was for the simple reason that you and me are using sulfonylureas in South Asia. We need to continue using sulfonylureas because they are cost-effective, they are safe. We know that, yes, they have certain issues of hypoglycemia and weight gain, but we also know that they are good, efficacious drugs, and I can use whatever I have in the armamentarium as far as management of diabetes is concerned. I do not believe in any kind of molecule bashing as far as management is concerned. But one very another important fact that we know about sulfonylureas is that there are certain differences between molecules. These differences could be because of binding affinities, these differences could be because of differing receptor interactions, and of course these differences could be because of duration of action. And on the background of this, there were 3 studies which were done, two studies which were done in India, Dr. Arvind Sir's study, another very elegant study done by Dr. Hasnain, and all these studies, you would be surprised, put across a very important factor that patients who were on actually glycoside modified release actually had a lesser incidence of hypoglycemia even compared to patients who were on DPP-4 inhibitors. That was a very, very surprising part of the entire study, because when you are giving a prescription to a patient who is going to fast during Ramadan, it's a preconceived notion that no, my patient is going to be on DPP-4 inhibitor, is definitely not going to have any kind of hypoglycemia, and my patient is going to be on any kind of SU, even if that is your glycoside modified release, is going to go into hypoglycemia. And because of that inherent fear, we do reduce doses. Because of that inherent fear, we may knock it off suddenly before Ramadan, and we land up with a lot of issues during our management during Ramadan. Now, when you talk about glycoside modified release, we know these are once daily dose regimens with low risk of hypoglycemia. And though we know there are major changes in dietary habits and patients abstain from eating anything from dawn to dusk, still we would like to see what kind of data we have when we actually use this molecule in a real world setting. And that was the entire concept behind this study, to study what is the kind of safety profile, what is the effectiveness of this molecule in patients who are planning to fast during Ramadan in an absolute real world setting, that is a setting which you and me are commonly in. And what was the design of this study? A very, very simple design. We were participating in this study, absolutely simple design. These were patients who had to be more than 18 years. These patients, the only exclusion criteria as far as HbA1c was concerned, patients with an HbA1c more than 9. Of course, patients with severe renal or liver dysfunction were excluded. Patients who were on insulin therapy were excluded. Any kind of contraindication to glycoside, patients who were pregnant, breastfeeding, or one very important exclusion criteria was patients who had any kind of severe repeated hypoglycemia during the previous year. But we also know that this is an exclusion criteria page. This criteria by itself puts our patients in the very high risk category as far as the guidelines go, and we are not supposed to allow these patients to fast. The most important inclusion criteria was that these patients should be on treatment with glycoside MR, 60 milligrams in a breakable form, whichever dose is allowed. This was on the investigator's discretion. And the most important thing, that this patient had to be on a stable dose of glycoside for 90 days prior to this patient being taken up for the trial. In this study, there were only 2 simple visits. One visit was before Ramadan, that was 6 to 8 weeks before Ramadan, where the patient underwent a basic clinical evaluation, which you and me routinely do in clinical practice whenever we are evaluating whether this patient is fit enough to fast during Ramadan. Yes, these patients need to be willing to do SMBG. A very, very important caveat with SMBG, even now at this point of time, is that a lot of patients believe that if they do SMBG during the fast, it somehow negates the fast and it is not valid during fasting. We are repeatedly using all kinds of educational forums to put across the point that patients can prick themselves during the period of fasting and it does not invalidate the fast. And of course, patients who are willing to fast during Ramadan was one of the obvious inclusion criteria. The other visit that these patients had was around 4 to 6 weeks after Ramadan was over. So one visit was the visit 0, which was around 6 to 8 weeks before Ramadan. And the second visit was 4 to 6 weeks post-Ramadan, because a lot of patients do not immediately want to come after Ramadan is over. So we gave them a broad window, a routine follow-up, which a lot of patients do during post-Ramadan. So very, very simple protocol. And the reason this protocol was called kept very, very simple, because this was what you and me do in clinical practice. The discussion prior to the protocol was that what do you and me actually do? And this is what it was put in a nutshell, that yes, this is what would be easily doable. This was a multi-center study. These patients, as I said, were on glycoside MR 60 milligrams. Routine practice was followed. The PI had discretion to decide what was best for the patient. And of course, the patient was given a diary for any kind of documentation of any kind of hypoglycemia or any kind of AE. And all this was collected in a ECRF, and it was regularly monitored during the study. What were we actually looking at? The one parameter that we all worry about, as I said right at the beginning, is hypoglycemia. So one of the primary endpoints which we were looking at is which were the patients who had at least one symptomatic hypoglycemic event, which was confirmed or not by a measured blood glucose concentration less than 3.9 millimoles per liter. Secondary endpoints were some of the parameters, again, that we use routinely. your change of HbA1c, your fasting, your weight gain between or weight loss between your visit 0 and visit 1. Conventionally believe that Ramadan should cause weight loss considering the fact that you are fasting. Our practical experience is that most of our patients do not have any kind of weight loss, or some patients also have weight gain. So that was another parameter that we were trying to look at. And of course, we were trying to see what were the proportion of patients who had at least one or more than one confirmed hypoglycemic event, and what were the number of patients who had at least more than one severe hypoglycemic event. These were the parameters which we were looking at when we started this study. What were the numbers involved? We finally managed to have 1,214 patients on board. And mind you, if you look at these numbers, it makes me feel very happy to see that there were almost 20% of patients from India, of which our center was one of them. The Asia-Pacific region was represented by India, Indonesia, Malaysia, Bangladesh, and the Middle East, North Africa was represented by Pakistan, Egypt, Saudi, UAE, and Kuwait. And this was the kind of distribution as far as the patient population went. The reason for choosing this kind of patient population was because the number of fasting hours more or less matched in this patient population, and on an average, these patients were fasting for at least 14.5 hours during this period of Ramadan, and it was uniformly summer in all these countries during this last Ramadan. Now, what were the baseline characteristics of these patients? You would realize that the mean age was around 54 years. The mean disease duration was not very long, around 5.4 years. The mean HbA1c was pretty good, 7.5, not that bad. And if you realize, if you look at this mean dose of gliclazide, that is the last row right over there, these patients were on substantial amount of gliclazide. The average dose worked out to be around 74 milligram, which is not that lower dose. That means these patients were on the dose that you and me use in clinical practice. And what were the number of anti-diabetes? These were the other comorbidities and the other co-medications that these patients were on. And the number of anti-diabetic drugs, if you see across over here, you would realize that 40% are only on gliclazide modified release, 30% approximately on gliclazide plus 1 OAD, and in the other 29% you would have gliclazide with almost 2 or more than 2 OADs. And which were those 2 OADs? Again, as I would expect, it would be the other major chunk would be patients who on gliclazide and metformin, which would be around 27%. And then we have a horde of other patients, around 16% on DPP-4 inhibitors, around 10% with SGLT2 inhibitors, and the rest who were on a combination of acarbose or thiazolidinediones. And what happened to the parameters that we had thought about studying? What happened to these parameters that you and me thought we would have big issues with as far as our patients go? This was very surprising to us. This was very surprising to us because I think as investigators, we also were not expecting this. But you would be surprised that during Ramadan, there was a very low rate of symptomatic hypoglycemia in spite of the fact that this dose of approximately an average dose of around 75 milligrams was being used in these patients. Yes, but the timing was changed. The patients who were, for example, on a morning dose of gliclazide, their timing was shifted to iftar. That is, instead of them taking it in the morning, you take it at iftar, which is something I think which we very, very routinely do in clinical practice. All of us shift the timings of the SUs from morning to evening. All our textbooks say that. So there's nothing different from clinical practice in that. Now, with this kind of change, what we saw that the patients during Ramadan, only 2.2% had any kind of symptomatic hypoglycemia, which actually these patients around had 0.2% and 0.3% pre-Ramadan and post-Ramadan. This gives me information about both situations. That is, yes, gliclazide modified release does cause a very low incidence of hypoglycemia even pre and post-Ramadan, and I can continue using it very, very safely in my patients during Ramadan. What about at least one severe hypoglycemia event? Again, came across as a surprise. When we actually looked at the data points, we were actually very, very surprised to see that during Ramadan, you would realize that 0% of severe hypoglycemia in your patients, and even pre-Ramadan and post-Ramadan, even a single episode of severe hypoglycemia was not seen. Confirmed hypoglycemia, yes, was seen. I do not want to negate the fact that yes, we can have hypoglycemia. So I do not want to take away that we need to monitor our patients. We need to explain to them regarding symptoms of hypoglycemia. We need to be vigilant during Ramadan. We need to be vigilant during any fast for example. But what I am trying to put across is that yes, in our patients who are on sulfonylureas, we need not really go on our back foot, we need not go on our defensive, we need not totally change the molecules pre-Ramadan and create a lot of chaos. We can continue these molecules safely, smartly, so that we can reduce the incidence of the one big problem that we expect during Ramadan, and that is hypoglycemia. What happened to efficacy parameters? What happened to the HbA1c? Conventionally, when I talk to my patients, to be very honest, I always think that they are going to come back to me with an increased HbA1c because of the feasting involved. We were very surprised again to see that actually there is a reduction of 0.3% in the HbA1c. So sometimes you realize that what you think and what actually happens as evidence may be really, really different. And sometimes we may have these, because we've been, as residents, even as teachers, we've always been telling our students that no, be very careful with SU, especially during Ramadan. There's going to be an increased risk of hypoglycemia. Your patient is going to go out of control. Your patient's HbA1c is going to go haywire post-Ramadan. And you would be surprised that these patients did not actually have an increase in HbA1c. And at what range this happened? I mean, you would think that maybe this happened at a higher HbA1c. You would be surprised if you remember the initial diagram which I showed you, the average HbA1c is 7.5. So even these patients with an HbA1c of less than 7.5, mind you, there was an improvement as far as the HbA1c was concerned in these patients even during Ramadan, and greater proportion of patients with HbA1c less than 7.5% was seen at the end of the study. Fasting, again, which I would to some extent maybe expect that there would be a change in fasting, but no, this was statistically significant and almost a 9.7 milligram per deciliter reduction in fasting plasma glucose. And mind you, maybe because we were monitoring our patients, but yes, we did see a reduction as far as weight goes, 0.5 kg, very surprising, but across the board it showed that there is a reduction of weight in our patients during Ramadan. So a lot of my preconceived notions which I had actually took a quashing after we did this study. So if I want to put this just in a nutshell, the last slide of the day, this is how I would sum up this entire study. 2.2% of symptomatic hypoglycemia is what we saw, 1.6% of confirmed hypoglycemia, a reduction of HbA1c of 0.3%, a fasting reduction of 9.7%, and a weight reduction of 0.5%, sorry, 0.5 kg. What does this mean to me clinically? What information this gives to me clinically is that if my patient is coming to me, walking to my consulting today and tells me I want to fast during Ramadan, madam, what do I need to do about my medications? If my patient is on glycoside modified release, I can safely continue it. I should not have a problem. Yes, I will continue monitoring my patient because monitoring is a cornerstone when you're managing diabetes during Ramadan. But I would breathe a little easy. I would step back a little and maybe not be that emphatic about wanting to completely change my patient's prescription if my patients are well controlled. Thank you very, very much.
Thank you, Dr. Sheikh.